Thank you so much for sticking with us. We are just coming to the end of our wonderful day of sharing and exchanging of ideas. I just want to quickly introduce our final keynote speaker today. We started the morning with Governor Green. We're now going to end the afternoon with a key player in Governor Green's administration, Dr. Jack Lewin. He is the founder of Lewin Associates, and he is currently leading Hawaii's State Health and Development Agency. So just a big, warm welcome to him, and thank you so much.
Mahalo, thank you. Well, it really is an honor to be here today. I'm excited about this opportunity, actually, because I have such a profound love for Hawaii and for the work we all do in healthcare here. I'm here really I'm back at the pleasure of our governor, Dr. Josh Green. And, he's a kindred spirit, so that makes things really kind of nice for me. And I also believe that he's capable of producing a kind of a Camelot, for healthcare at least, in Hawaii. And we need one. Think back to the original legend with King Arthur and the Knights of the Round Table. For medieval England, they created justice and peace and prosperity. But then, Sir Lancelot had an affair with Guinevere, the queen, and Camelot was gone, right? And so, but the point is, Camelots are like that. They're ephemeral. Every once in a while, there is a bright moment where things happen, where expectations rise, and people meet new expectations. And it's kind of an opportunity that you have to open your eyes and see and participate in. And I actually feel like that is where we are now. And you got to take advantage of it. Remember back to the Waihe'i years when I was director of health. And to me, that was a Camelot. And for healthcare, it was. We had the Prepaid Healthcare Act finally after years of being tied up in courts. We got all the uninsured covered with a different kind of model. We got the Medicaid program moving toward where we now have is MedQuest. That was an amazing transitions were going on at that time, and it really was quite heady. And look, it was noticed. This guy named Bill and his wife Hillary came out to find out what was going on. And she based her strategy on health reform on Hawaii's plan, although she took 12 pages and turned it into 2,500 pages, which had some difficulty, making its way through Congress. But a brilliant person, just a perfectionist. Then California came out and said, and I went back to help Hillary, by the way, and I tried to say keep it simple, but she really wanted to go for everything. Then California came. Governor Gray Davis, Speaker Willie Brown, and said, Jack, you've already come back and spoken to the legislature about this, but we want you to come actually and help us pass the law in California. So I did. I actually was the CEO of the California Medical Association as a day job, but we got the law passed in California, and why don't you remember that? I mean, it's amazing. Wouldn't it have just transformed everything in America? Well, it would, but there was a guy named Arnold who ran for governor shortly thereafter, and the GOP insisted that he run a ballot initiative, and by 0.5%, they killed off the Prepaid Healthcare Act in California. But the fact is, what we did got noticed by the entire country and by the biggest state in the country. So it is important, and those years are great. And I think at that time we were talking and thinking about, just like now, what is a decent society? What is a democracy? What do we do for our citizens and for ourselves if we're really going to fulfill the mission of that? At least 5 things come to mind for me, for all citizens, and it all is around opportunity. Okay, opportunity around education, critically important for every person. Everyone should have the same opportunity. Opportunity around public safety. Opportunity around environmental well-being. Opportunity for those at the lower end of the income spectrum for food security, and for housing, especially for kids, and opportunity for quality health care for everybody. Very important, because that's the opportunity to have a full and productive life. So some sort of likely naive people have labeled me a health care futurist. I don't really know. I mean, Yogi Berra was right when he said, making predictions is tough, especially about the future. And then another thought comes to my mind: a wise man once said nothing. But I'm actually going to say something here today, because I think this audience is really where the responsibility for our future in healthcare kind of rests, right here. I was thinking about my mainland adventure tour back to Hawaii. It's so nice to be back, at the feeling of it, the ohana. Really never, we kept our house on Maui, so we really never truly felt disengaged. But, I had a lot of interesting experiences. The American College of Cardiology, working with Congress as the chairman of the National Coalition on Healthcare, then up at Columbia University in New York, sitting on various boards there, but also working on the research world, the Cardiovascular Research Foundation. And, I got back here and I was thinking it's great to be back. I'm glad for some of the educational experiences I had. And I went to talk to a legislator who I greatly respect and who I knew back in the day. And we were catching up. And she was saying, well, we need to do this. And I'm saying, well, we can get that solved. She goes, well, we also need to. And I said, we can get that done. Had a bunch of examples. And she said, Jack, after your mainland adventures, have you become a little bit of a know-it-all? And I said, Senator, you know how I know I'm not a know-it-all? She said, how? I said, I'm married. But, I'm really not here to say that I have the answer, and I'm up to this. This is up to all of us to do together. I mean, that's what Governor Green asked me to consider, collaborating, bringing people together to collaborate on a future. But the thing about it is, what about that future? What about our present? Well, in many ways, Hawaii is a really pretty healthy place, right? We have the greatest longevity in the country. We're always in the top 3 states for health status, according to CDC, year after year after year. We have the lowest per capita spending in Medicare of any state. I could argue that some of that is due to the fact that a lot of people aren't getting care in rural areas and in some of the populations that don't get all the care that they really need. But we have these great stats, and others, I think, so we're pretty good. But, I think we all know, and that's why we're here, we're not good enough. We know we can do better. That's why we're here. And, the primary care, we are 50th out of 50 states in terms of at least what the HRSA agency and the Census Bureau says, access to primary care. More than 35% of people in Hawaii don't live near primary care and have to travel a significant distance. It's quite a hurdle. That's true in terms of health equity for us, our Native Hawaiian population, our Pacific Islander population, even elders in rural areas. We have a lot of equity issues to tackle. Access, we still have a persistent uninsured population here that's not huge compared to most parts of the country, but it's here. And it's kind of hidden. It's like the guy who cuts my hair, the guy who does the woman who does my wife's nails, the Uber driver that picked me up the other day. I keep talking to people about this, and I'm impressed with how many times somebody says, well, I'm going without it right now. And I think that, if Judy Moore Peterson was able to talk to them, we'd find a way to get them covered here in Hawaii. But there are people that aren't covered, and we have to face that. We have one more thing to consider, and that's cost. Because we are, it's not unfortunately, but we are part of the American healthcare non-system, are we not? And it's a mess. It's really a mess. And there's some good things about it as a physician. You know, when I was coming out of training, what we did for heart attacks is we put you to bed, rest for weeks. We put you a little bit of morphine, oxygen. That was it. Compared to now, when we can, treat most times we can treat a heart attack and have you go home that same day. So, there's a lot of progress we've made. It's impressive. It costs a lot. But we are in this system that costs twice as much as per capita as the other developed nations of the world that have universal coverage. And they've got two things going that the systems are different in all these developed countries, really. If you look at them, they're not all the same. But they have two very important things in common that the U.S. doesn't have. One, everybody's in, a defined set of benefits, there it is, and everyone's covered, no question. Two, there is a common overarching administrative and regulatory system instead of the complex nightmare we deal with in this country, in that same area. I mean, just so many different regulatory and administrative issues to deal with. And we spend twice as much. But, there might even be a third thing that's different about us in the U.S. healthcare non-system. And, Don Berwick is a good friend of mine. Some of you may know him. Don has, started the Institute for Healthcare Improvement, and he was the administrator of CMS. He's a dear friend. He's a very, very smart guy, and a real opinion leader. And he says, he just wrote about 8 or 9 months ago an article in JAMA, a lead article, about something that disturbs him in healthcare, which is a growing trend toward greed in healthcare. As healthcare becomes more corporatized, it was a disturbing article, really, but one that needed to be written. I'm not going to dwell on it because I think everyone in this room is here for the right reasons. I really feel absolutely sure of that. But, I'm a doctor, and we've historically made quite a bit of money as physicians. Maybe not so much today, but we did over the years. I know there's a lot of doctor friends of mine here that are really, really upset about the general excise tax if they're solo practice docs out there or small practices, that we are one of 2 states that taxes these practices. And there are a number of issues that people feel like disadvantage us in that physicians leave or retire early because it is an expensive place to live, and it's gotten much more expensive. And the requisite, the comparison of the income to the cost of living hasn't really gone up as much. So, there's that. And I don't want to dwell on this whole thing, but I should go back to I just might be full disclosure. I was, a U.S. Public Health Service doctor in the Indian Health Service. I didn't make any money doing that, but it was a great experience for 7 years. I was a doctor, a primary care and critical care doctor, and ICU, but community care in Maui for a lot of years. I didn't really make a bunch of money there. And then I was director of health, and believe me, that was definitely not a money job, even though it was $1 billion agency. But, in full disclosure, then I went off to the mainland, and I had those 7-figure salaries. So, I can't really, I'm not here to judge anybody or pontificate about it. But I want to say that Berwick makes the point that, the healthcare is increasingly being run by shareholders in the stock market. And there's a lot of money being pulled off the top. And it's something we have to at least consider, because most of Hawaii is a nonprofit world still. So Hawaii still has a lot of that old philosophy about healthcare that's here, and I think it's valuable for us. And I think that, whether you are a not-for-profit company or a for-profit company in Hawaii, I think all of us need to just sort of focus on it, that we're all going to do the right thing. So, but that's got to be part of it, because aloha means something. and ohana means something. It's real for us. So that is the point. However we position ourselves in terms of whatever's going on in the mainland trends, we're different. And we want to make sure we're different. If we bring people in, they need to be part of this new world of aloha and ohana with us. But we're in a nation that is really, really adrift in this regard. We're spending $4.6 trillion this year on healthcare. That's way bigger than the military budget. And we're spending, at least the economists tell us, we're going to be spending very close to $7 trillion by 2030, which would kind of be, for an average family of four, if you're like in most mainland states now, it's $30,000 for coverage for a family of four. It's going to go up to $50,000. I mean, we're talking about unsustainable kind of things here. And so, this is just the fun part of my talk, by the way. No. Who's going to save us from this kind of trend? It's not going to be Congress. And, I would say that the cynics in D.C. kind of like to, make snide remarks like we have the best government money can buy and all that sort of thing. But we have a potential Camelot right here, right now, where we could, the governor mentioned it this morning, set the stage, set a tone, set a direction. It happened before. It's not like it's new here. We have a whole tradition of health system reform in this state. And so, the question, though, is who's in charge of, it's not me, but who's in charge of creating that better future? Is it going to be the patient? I don't think any of us would think the patient's in charge of the future. I see Mark Alexander here. Are doctors in charge, Mark? I wouldn't say so. We used to think we were, okay? I think we're kind of siloed in terms of who's in charge. And it's uncertain. Our legislature, I think, really is sincere about what they want to do, but they aren't experts in healthcare. And they can't lead this process. So if we knew who was in charge, then we could say, what should the goals be? What should we do next? What should the steps be? And the one thing I think everyone in this room can agree on, not the status quo. That isn't the future. So, if we know that's it, then what next? Now, Bernie Sanders has a third of America standing with him and his plan, which he inherited from Ted Kennedy, obviously. And you know what? He's never going to get it through Congress. It's not one of the options, actually. It's there. It's a good gesture, a nice thought. He's going to get rid of insurance companies. He's going to get rid of for-profits. He's got a whole strategy there, but he doesn't have the votes to get it, to get to at least universal access to high-quality, equitable, affordable health care for all, which is the goal we should all have. So I wanted to put some things on the table that we should be considering in those regards if we're going to go there together. And there's some things that we need to develop as part of our infrastructure to achieve that kind of a goal. And I think that one of the most interesting high priority things that we often don't put at the high priority is data. Having the information we need to manage our way toward that goal and to know we're getting there and to really know it's reliable. That's just critically important. And we're already living in the future. Actually, there's a company called Milliman. Most of you have heard of, a big global company worth billions and billions of dollars. Milliman already has all our data here in Hawaii. They have everything. And they're already doing things with it for the federal government and for corporations and for employer groups. I mean, they actually could produce for us right now all the stuff we're trying to produce ourselves. And I want to call out that there's some really good things happening in Hawaii that put us in a good position there. We have some. We're making some real progress in that regard. We have the all-payer claims database. I saw Ranjani Starr here. She's running that. It's under the authority of SHPTA, but MedQuest and UH are actually managing that, and there's 1 million patients' data already in that system, which is pretty impressive. And that's progress. I see Francis over here with the Health Information Exchange, also a very impressive institution that has all the data from the hospitals, has a lot of it, not enough of all the outpatient data, but a lot of it. Very, very valuable. People are using it. I saw Hilton Rathel here, and he and Haley and his group have done fantastic things with the Laulima database. And if we all were not too competitive, siloed, and proprietary, we took all three of those sources and integrated them in whatever collaborative way we could. We really would be far down the road for being able to manage our way toward that bright future and actually knowing we're getting there for real. So that's exciting to know we have that, but we haven't wired up all the small doctors, the school health clinics, the rural clinics, and all those places to really bring them in integrated in interoperability. We need to do that. That's essential if we're going to know how we're doing. And all the FQHCs are there, but they can't afford to go. Everybody can't afford to go Epic, right? So we need to find a way to help people afford to bring this all together so we have everyone connected. And that's a huge goal for us. Secondly, we've got to reconcile the cost of drugs and technology. We're spending a lot of money there. 5% of prescriptions are biologic drugs or biosimilars, and they're 50% of the cost, and that's going up and up and up. Some of my colleagues tell me that now for the newer drugs for lymphoma, leukemia, multiple myeloma are going to cost $1 million a year. And we just have, who pays for all this? All the technology in the cardiology world. We've done so much there. It's amazing, but it is very expensive. And so the question is, science is on a roll, technology is on a roll. How do we pay for this stuff? Does everybody get it, or just some people? Or to try to get all this stuff done, we also have to get to new patient models. New payment models. We've been talking about that here in a variety of venues. We'd like to. People think across the country, and the policy side, even the GOP side, the Democratic side, generally believe together that value-based reimbursement is a direction we should be taking, that we ought to be producing better outcomes at lower costs. It's doable. It's possible. We're spending twice as much as any other nation. There ought to be a way to get this done. And so that seems to be a common theme, but getting there isn't real easy. We've got some work and some pilots in this state moving in that direction. Our MedQuest program is there for sure. And it's kind of going back to say, what are the good things that we have? Well, I'll talk about that in a second, but I think we really need to look at the new payment models. We need to implement them. We need to be bold enough to do it. We're going to have to pilot and find out what works and then move forward. And the workforce issues. I think this loan forgiveness thing is a magic accomplishment of Governor Green. That's fantastic. I love it, but it's not going to be enough. I mean, I still think we're, just looking at the cost of living and so forth and talking to docs all over the state. I think I've had something like 500 stakeholder meetings, this year about these topics. It's been a real privilege to hear from so many people, and I've learned a lot. I do think that it's tough for primary care doctors with the reimbursement and the cost of living here. I think it's tough for nurses when they compare their salaries to, and for the whole spectrum of healthcare workers. So, I think we have to think about that. And then part of this delivery system change is we're going to have to think high tech and high touch at the same time. You don't want just high tech, right? You want high tech and high touch. So how do we do that? Well, we're going to have to leverage the doctors and the nurses and the social workers and the psychologists and all those people to be there for more people per capita. And to do that, we're going to have to be thinking of different ways to touch, like community health workers. We developed community health workers in the Indian Health Service all the way back in the 80s, early 80s. So we can take people and train them up to be the touch and even be the technology link, so you can do telemedicine consults with nurses and doctors and specialists and so forth, and reach many more people much more effectively and much more conveniently in their homes, in their communities where they are. Not every bit of care is going to be that. You got to do some of it in person, but that's a lot of it can be done that way. Kaiser Permanente discovered, this is back a decade ago, just by making their doctors answer every email message the patient wanted to send them, that they literally reduced, in many parts of the Kaiser Permanente world across the mainland, 50% of the outpatient visits were reduced. With the happier patients, And the doctors weren't happy at first because they were sitting up doing the emails at night after they went home. They said, hey, I think we're going to need a little bit of time during the day to get this done. But, and that did come about. But what a savings, and it was just with kind of a low-tech answering emails. So there's a lot we can do with high-tech and high-touch. And look, in long-term care, $200,000 a year on average for somebody in a nursing home. If we put $100,000 into really good home care, $300 a day, that would be, we could keep at least half the people that are heading for that, in that direction, home where they want to be or in their community where they want to be. And we have a lot of good things going for us here that could make that possible. And then that other $100,000 we'd be saving, half of that, we could negotiate with the feds. We redistribute that to increase the money that's available to us. It's a huge opportunity in front of us, and it's kupuna care redesigned and palliative care really fully instituted and thought of in terms of new ways. And look, our FQHCs and our rural health clinics and all those folks are doing amazing things as well. We've got to bring them all into this data system with us and this part of this model because that's a critical part of our whole system, which we're very fortunate to have. Hospitals, we should develop a higher acuity for the people that are in there and be treating the rest of the people in the home and community with new models of care. Save a lot of money, it'll be better, it'll be good for the hospitals, and the hospitals should be thinking, this is how that value-based reimbursement kind of thing is going to work. They're also responsible for improving the health of the community, reducing the flow of patients to the hospital that don't need to be there, and people to the ED that should really be getting care somewhere else. So this is doable stuff. This is a place where we could get stuff like that done. And I got to congratulate, I think Hilton is really a wonderful leader for our hospital association and gets that. And so do many of the execs that I've talked to around the state as we chat in this regard. So I think we can do that. And the insurance side of thing, look, let's prove Bernie's wrong. You have value. There's a reason for you all to be here with us. But let's do it in a way that puts the patient first, actually measures patient satisfaction, uses more patient-reported outcome measures, because actually they're more valuable. I learned through an institution I helped start with Harvard Business School called ICHOM, that's International Outcome Measure Comparisons around the world. We learned that we got better information with just simple patient-reported outcomes about their procedures than we did from reading their charts. So there's a lot we can do there. It's really kind of exciting. So everybody's involved. Everybody's got a job. And we do have a head start. Look, the Prepaid Healthcare Act is an amazing thing. No other state has it. And people don't quite understand it. They go, all the tax money you're putting into that doctor, and that's just a lot of money. No, look, the Prepaid Healthcare Act doesn't have any tax subsidies. It's just an increase in the cost of goods and services between the employer and the patient and the employee have an agreement to split the cost of health care. The employer pays more than half in most cases, but that's the basic promise. And then the cost of the hamburger, actually it's a Spam musubi here, goes up 15 cents or 20 cents, and everybody has health care. You dry clean your shirt, you're spending 10 cents more per shirt, everybody has health care. So, it's a very efficient way to go. That's why Hillary wanted to use that as the platform for her model. Because you have that, and you have the Medicaid which is for us MedQuest, and the Medicare wraparound, and you can start working on how you get all the way without some really radical change. Vermont tried to go, look, they have Bernie as their senator, they had to do it, right? And they tried to go for Medicare for all. And their individual taxes went up so much that after 1 year, the public voted it out. And Bernie said, look, the employers cheated here. They just took profit. They should have raised their wages, so it was going to be easy for the amount of money that no longer they had to forego. But of course, they didn't. So we should look at the Prepaid Healthcare Act as a super valuable part of what we have to build around. It's amazingly good. And MedQuest, I mean, Judy, fantastic, you and your team. You guys you're way out in the front of really leading the charge and making that one of the very best programs anywhere. So that's a big plus. The data stuff I talked about, we have a start, and it's a good one. It'll take us a little while to put it all together, but you know what? We can do it. And you know what else we've got here that's great? You all know this. We have community activism. We have things happening at the community level where people come together to care for each other. We saw that in Maui. We're seeing it anytime there's a crisis in Hawaii. You know, we have that. It's important. It's vital. And we're small enough that we can know each other and we can work together to solve problems in far less complexity than other places are having to deal with if they try to head in that direction. So there's a lot going on there. I have a super fondness for Maui because that was where I did a lot of my early practicing, and that's where my family, my wife and I raised our family. But the wildfires are, at this point, rightfully, every dollar that's not nailed down is going there to try to help us there, and with the economic downfall that's related to that. So this is a tough time in a way. And the question is, who will save us again? Judy Peterson and I have thinking that the HEAD grant is really one very good way to do it, because it actually has a lot of these aspirations I've been talking about built into it. And it's a 10-year grant with a lot of money, so we better get it. We better be one of the 8 states that gets it and move forward on that. It's critical. We're going to need some of you in the room here to help us with it. Make sure our proposal is reflective of you as well as the bigger picture, because that is one way we can go at this time to accelerate our path. But again, even that alone isn't going to save us. I mean, I don't know whether we pray or do we meditate for someone to save us. I mean, I'm reminded of a Zen metaphor. If a man goes deep into the forest and there's no woman there, is he still wrong? Okay, this is kind of a silly metaphor, but in this room, we have a lot of really smart women, a lot of really smart men. We have a lot of people who are dedicated to a super bright future for us. So I'm encouraged by what we have here. And I want to tell you a little story, it's just something that kind of brings this home. I speak to a lot of physician groups around the country and, healthcare organizations, and a story I like to tell when they're frustrated is, about who will save us. I'm reminded of one of my hobbies in life is, for years and years, even just right after medical school, a group of my fellow young physicians, we started going into the Sierras every summer for a week and doing a big, long backpack and climbing a mountain every time. And, quite an adventure kind of thing. As we were getting older, it was getting a little tougher, but we've continued to do it. The only time we didn't was during the 2 COVID years. We couldn't. But anyway, I'm reminded when you're standing at the bottom of a mountain and you're looking up there and say, hey, that looks easy. When you get to the top, it's almost always a lot more difficult at that last little bit than you ever thought it was going to be. And so I'm reminded of a guy in this story who is making that mountain climb by himself, and he's way up there, and he sees at the end, oh my goodness, there's like 150 feet of like a little spine between where he is and that final summit. And that spine has like, multi-thousand foot drop on either side of it. But it's about 1.5 feet wide, and he realizes he can do it. He can walk across that. He can get his courage up. It's a little scary. So he starts across it, and he's looking at the peak ahead of him. And as he does that, he has this existential moment. He says, oh, this is so beautiful. Who am I? What's it all about? And he got so caught up in his moment that he slipped, and he was going to fall to a certain death, except he grabbed onto a root, swinging around down there about 100 foot below the spine. And he's swinging down there, and he looks up, and he said, hey, anybody up there? Help me. He's asking for somebody to save him. And he knew there was no one in sight when he was up there, but he was calling out anyway. And this soothing voice spoke to him at that moment and said, I'm here for you, my son. Let go of the root and you'll be saved. And the man, his eyes opened wide. He looked up. He said, is there anybody else up there? My point is we are going to have to save ourselves. It's us. And the governor's asked me to help get you to collaborate on how we get to universal access to high quality, equitable, affordable care for everybody, and to make it affordable into the future. And all of us in this room, we can do it if we put our heads and minds and spirit to it. We can do it, and we will do it. Thank you. Ahui kako. Hui hau.